Okay, tonight I'm going to go over rheumatoid arthritis, gout, and calcium homeostasis. First question is, a 65-year-old woman receives a diagnosis of rheumatoid arthritis 1 year ago. At that time, her rheumatoid factor titer was 164. She presented with joint inflammation in both her hands and about 45 minutes of morning stiffness. She began therapy with oral methotrexate and currently receives methotrexate 15 mg weekly, folic acid 2 mg daily, ibuprofen 800 mg 3 times a day, and omeprazole 20 mg daily. At today's clinic visit, the patient reports the recurrence of her symptoms. Radiographic evaluation of her hand joints reveals progression of joint space narrowing and bony erosion, which is the next best step for treating this patient's RA. There's your choices there. The second question here is, missed it. No, that's the first question. All right. So rheumatoid arthritis is a systemic disease characterized by bilateral inflammatory arthritis, and it usually affects small joints of the hands, wrists, and feet. It can occur at any age, but has an increasing prevalence at up to age 70. Chronic inflammation of the synovium leads to proliferation and development of a pannus. The pannus invades joint cartilage and eventually leads to bony erosion and joint destruction. So in this example, you've got kind of your joint here, and this is what would be considered normal, with a normal joint capsule and the synovial membrane and the synovial fluid. And in rheumatoid arthritis, that fluid in that space gets invaded by this formation of a pannus, which has hypervascularization, and then it invades that space and leads to bony and cartilage destruction. So to diagnose rheumatoid arthritis, patients will present with joint pain and stiffness and the fatigue. Laboratory markers usually show a positive rheumatoid factor, an increase in the erythrocyte sedimentation rate, and also an increase in CRP, and then anticyclic citrullinated peptide antibodies, and normochromic normocytic anemia. RA can affect other organs, causing pulmonary fibrosis, vasculitis, and dry eyes. Classes of anti-arthritic drugs, we have NSAIDs, which you should be familiar with. And then we have what are called DMARDs, or disease-modifying anti-rheumatic drugs. And these can be broken down to two classes. One is the non-biologic DMARDs, or what we would consider traditional DMARDs. Typically, they're oral medications. And then we have the biologic DMARDs, which are typically injections. And then, of course, there's glucocorticoids, corticosteroids. So the 2015 update on the American College of Rheumatology has guidelines on the treatment of rheumatoid arthritis. I attached that to Blackboard, but you could also download it here using this link. These are some of the scales used to measure disease severity, and so they'll ask the patient to fill out these scales, and we can kind of see how the disease is progressing in patients and whether treatments are being effective or not. So we have patient activity scale, routine assessment of patient index, so on and so forth. This table is kind of a summary of the agents, so you can see the non-biologic DMARDs, methotrexate being the gold standard here, and some of the comments. And then the biologic DMARDs, most of them being tumor necrosis factor inhibitors. Then there are the non-TNF inhibitors, and these can have a wide range. They can inhibit interleukin 1, interleukin 6, CD20, so on and so forth. And then this one is, I think they're like kinase inhibitor, tofacitinib. It's a Janus kinase inhibitor, and we'll go over that later on. So anti-inflammatories used for immediate pain and inflammation relief, none of which alter disease progression. So these aren't considered DMARDs, but they do help with the pain. And so, of course, we have NSAIDs and steroids. We won't go over those because we've covered them in other lectures. So the gold standard non-biologic DMARD, and typically the first drug of choice for patients with RA, is to give methotrexate. It is the most rapid acting DMARD, and most effective if you initiate it within 3 months of the diagnosis, along with an NSAID steroid. Now, just because it says rapid acting in here doesn't mean that rheumatoid arthritis is going to be cured the next day. It still takes several weeks, as you can see here, 3 to 6 weeks, but it is much faster than any of the other agents, and so this is why we use it. And again, to kind of cover the time period where the methotrexate is kicking in, we'll often add an NSAID or a steroid. And then as the pain improves, then we'll start to reduce or taper off the NSAID or steroid. Now, if the patient is not tolerating the medication, the methotrexate, you can reduce it, but it's typically not recommended to stop it unless it's a severe reaction. And the dosing can vary, but you keep in mind methotrexate in this situation is going to be dosed weekly. And it's going to be 7.5 to 15 milligrams, at least initially, but you can go as high as 30 milligrams a week. And the suggestion is if you're going to go 5 milligrams or more, you should give folic acid, and that helps to decrease some of the side effects. As I mentioned, 3 to 6 weeks for it to kick in. It has some effect on the liver, so we should be monitoring LFTs. It can lead to bone marrow suppression, GI ulceration, and also pneumonitis. While we're on methotrexate, we'll want to monitor renal and hepatic tests. Sulfasalazine is indicated for inflammatory bowel disease, but it can be used for RA as well. It's typically second or third choice because of its intolerability. But it can slow progression of joint deterioration. This GI side effects are very pretty harsh. Nausea and vomiting can be a big thing. But it is safe in pregnancy, but again, this is slower on onset versus methotrexate at that 3 to 6 weeks. These are some of the other non-biologic DMARDs. This one, leflunomide, or brand name Arava, is pretty similar to methotrexate, but it can cause more hepatotoxicity and teratogenicity. If a female is on leflunomide and wanted to get pregnant, there is a way to kind of speed up that process, and so they would give cholestyramine, which is a bile acid binding resin typically used in cholesterol hyperlipidemia. But cholestyramine can help bind to the medication and then help to eliminate it quicker. And so the dosing here would be to give 4 grams every 6 hours. We'll do that for 2 weeks. And that's because leflunomide itself has a pretty long half-life, averaging about 18 days. So that's a pretty long time. Another agent is hydroxychloroquine, similar to leflunomide in that it is slow in onset. Sulfasalazine. So sulfasalazine and hydroxychloroquine, for both agents, are slow in onset. The thing you gotta remember about hydroxychloroquine, which is used probably more for lupus, but lupus and RA, is you have to have baseline eye checks, and then to repeat that every 12 months. And what we're looking for is retinal toxicity. Okay, now moving on to biologic DMARDs. This slide, anyway, will cover the tumor necrosis factor inhibitors first. So they will suppress immune function, which obviously would pose a risk of serious infection as your white blood cells or absolute neutrophil count goes down. But how they work is they do neutralize tumor necrosis factor. Typically it's tumor necrosis factor alpha, which causes a lot of the inflammation. So we have etanercept, which is, I think, the first one of this class. The next one was adalimumab, which is Humira. And then a lot of the Me Too drugs started coming out, certolizumab, golimumab, and then infliximab. So like I said, they inactivate tumor necrosis factor. It can be used for moderate to severe RA. We do want to avoid it in patients who have heart failure because it could worsen that. These are the non-tumor necrosis factor DMARDs. So abatacept inhibits T cell activation, anakinra inhibits interleukin-1 receptor antagonist, in the interleukin-1 receptor. Rituximab is an antibody against CD20, and this one is a continuous infusion and can cause some serious infusion-related reactions. And so if it happens, it's going to be most likely anaphylaxis, and so you would need albuterol, epinephrine, oxygen, and steroids to manage that. Then we have tocilizumab, Actemra. It's an interleukin-6 antagonist, and so if you'll remember, tumor necrosis factor, interleukin-1, interleukin-6, those are probably your top three markers that cause inflammation. And then lastly on this slide is tofacitinib, or Xeljanz. It's a Janus kinase enzyme inhibitor. A couple of things to look out for. So with the DMARDs, really all of them, is an infection risk. We are trying to prevent the body from attacking itself, and in doing so we can lower absolute neutrophil count or white blood cells, and that puts us at higher risk for infections. But yeah, particularly look for pulmonary infections and sepsis in patients. We do screen for tuberculosis, and if you are positive, then you would have to treat that first before starting your biologic DMARD. Myocarditis and heart failure account for 40% of all deaths in RA, and so many consider rheumatoid arthritis an actual cardiovascular risk equivalent. The European guidelines suggest multiplying whatever 10-year risk score you get with ASCVD, and then multiplying that by 1.5 if you have rheumatoid arthritis. So we also want to give vaccinations prior to starting a DMARD or a biologic, and we want to wait 2 weeks before we get vaccinated. We do want to avoid any live vaccines though, just because our immunity will be shot. So cancer is more common in patients who are on the biologics, particularly GI cancer, some lymphoproliferative disorders, and melanomas. And so if you are melanoma positive, or actually if you have any of these conditions, it might be worthwhile to look at the non-biologic DMARDs of the biologic DMARDs if you can tolerate it. And osteoporosis is more common in patients with rheumatoid arthritis, and you'll want to consider a bisphosphonate, especially if you're going to be taking steroids for a prolonged period of time. Okay, so back to the question about the 65-year-old woman. So radiographic evidence suggests joint space narrowing, bony erosion at the hands. Which is the next best step for treating this patient's RA? Would it be to give etanercept, to change to leflunomide, to add prednisone bridge therapy, or to change to hydroxychloroquine? And the answer is etanercept. And again, because she's been on methotrexate, 15 milligrams weekly, so that's a proper dose. She's been doing that for, we can surmise, about a year. She still has radiographic evidence of an issue. But yeah, that would be the answer. Proper. Change to leflunomide, if you remember, that is just a secondary choice and typically given if the patient doesn't tolerate methotrexate. There's no indication that the patient is not tolerating methotrexate just fine. It's just that her disease is progressing, so that wouldn't be the right answer. We would typically avoid prednisone bridge therapy because this patient is also on a high dose of NSAID, and NSAIDs and steroids can really increase your risk for gastric ulcer, so we tend to avoid that. And then again, hydroxychloroquine is another one of those second-line therapies if the patient doesn't tolerate methotrexate, but there's no indication here that she is not. Okay, now moving on to gout. 16-year-old man, 80 kilograms, presents with his third gouty attack of the past year. His last attack, for which he took colchicine with relief, was 10 days ago. He is experiencing pain in his left knee and in the third and fourth proximal interphalangeal joints of the left hand. The pain started 10 hours ago. Patient rates his pain 6 out of 10. He also has COPD, dyslipidemia, and normal renal function. His serum uric acid 1 month ago was 10 mg per deciliter, and for a range, it should be 3.4 to 7 as being normal. He has no tophi. He currently takes tiotropium, albuterol, and simvastatin. What is the most appropriate for treatment of his gouty attack? And then, same patient, which treatment is most appropriate? A, B, C, or D? Okay. So gout is a recurrent inflammatory disorder caused by hyperuricemia, and this would be a serum uric concentration greater than 6.8 to 7. And the problem with gout is that it can lead to tissue deposition of monosodium urate monohydrate crystals in the extracellular fluid of the joints and other sites. It is the most common rheumatic disease of adults, and there are some episodes of severe joint pain, and it's typically in the large toe. When patients suffer this, we call that podagra. And gout is typically caused by excessive production of serum uric acid or uric acid, and then impaired excretion of uric acid. So in the diagnosis, tophi may be present, those crystals, as detectable on physical exam or with imaging. Patients who are suffering from gout may have some renal manifestations, including urolithiasis or kidney stones. And acute gouty attacks feature severe pain, redness, swelling, most often occurring in the lower extremities. So the most common joint is the first metatarsophalangeal joint, which would cause podagra, or the knee. They can occur in many other joints, including the upper extremities, and they may be polyarticular at first presentation, although that tends to involve less than 20% of cases. Ideally, definitive diagnosis requires that you fluid aspirate the affected joint during an attack and then visualize the fluid through light microscopy. But of course, getting a needle aspiration for a gouty patient is usually not done, nor is it practical. And so we can base our diagnosis on the combination of the presentation of the patient or the clinical picture and the uric acid level. And then just note that the serum uric acid level can decrease during an acute attack or flare, so don't use that as the sole diagnostic indicator. And since the SUA, the serum uric acid, where did I leave off? Sorry about that. Oh, yes. So that serum uric acid tends to decrease during an acute attack, so we'll wait a couple of weeks at least before remeasuring that. Predisposing factors for gout include the diet. So if you have a diet high in meat and seafood, fatty foods and beer, sugary drinks and high fructose foods and drinks, who is not on such a diet? Drugs, so thiazides and loop diuretics, niacin, calcineurin inhibitors, and aspirin up to 325 mg a day can cause predisposition to gout. And then disease states. So we have obesity, diabetes, hypertension, dyslipidemia, metabolic syndrome, heart failure, chronic kidney disease, early menopause, so on and so forth. So there are quite a few ways to stage gout. There is what I call timing. So there's acute gouty arthritis, intercritical gout, which is in an interval between attacks, and then chronic recurrent gout. And then there's also the size of joint involved, sizing, large joints, medium joints, and small joints. So the treatment here for gout is to reduce that serum uric acid level to less than 6. If tophi are present or the patient is still symptomatic, then we'll try to drive that down to 5. And of course, we want to decrease the frequency of gouty attacks. So here are some of the non-pharmacological treatments in table format. You can see some of the foods and drinks to avoid, and then some of the lifestyle goals. So an indication for urate lowering therapy is to, if you have tophi are positive on the exam, or if you've had 2 or more acute gouty attacks per year, if you have chronic kidney disease stage 2 or worse, or if you've had past kidney stones, then you would qualify to start urate lowering therapy. You can initiate urate lowering therapy during an acute attack, but you guys gotta remember that you want to give it concomitantly with some kind of anti-inflammatory, and again, those would be NSAIDs or steroids. But really, the first line ULT is the xanthine oxidase inhibitors. Allopurinol was the first of its class in that one, and then febuxostat was a more recent addition. And then there are some alternatives. Probenecid is what we call uricosuric, meaning it does increase the amount of uric acid in the urine. But it is contraindicated if your creatinine clearance is less than 50, or if you've had a history of kidney stones. If the uric acid is increased, you typically want to avoid probenecid, and that's because it means there is an overproduction of uric acid. And then I want you to think why we would avoid probenecid if there's an overproduction of uric acid. And then we want to initiate anti-inflammatory treatment at the same time. So the initiation of ULT may cause an early increase in the acute number of gouty attacks, and this may be due to a rapid decrease in uric concentrations, resulting in remodeling of the uric crystal deposits. But it's important to tell patients who you're treating with gout to expect this. And once they expect this and it happens, they usually live with it and they're okay. If by chance you don't tell your patient, they'll be surprised and they will hate you because they'll think you don't know what you're doing, and they'll be having increased gouty attacks. So for anti-inflammatories, first line would be either colchicine or NSAIDs. Probably NSAIDs more are better tolerated. And then I would say for second line, colchicine / steroids. In any case, whatever agent you choose, just remember to continue that for 3 to 6 months before you just turn it off. Once we start therapy, we'll check the SUA every 2 to 5 weeks. And again, if you remember, we don't want to take it too close, or at least before 2 weeks because of a false lowering. Once you've achieved your goal, you'll monitor every 6 months. If not achieved, you can increase allopurinol. Although, like with any drug, an increase in dosage doesn't usually mean an increase in benefit. It just means one thing to note here is allopurinol is renally dosed, so you just got to be careful, especially pushing the dose if the patient has renal failure, as it tends to cause more side effects. Especially with high doses, you can get rash and then transaminitis. Now, if you're already pushing your xanthine oxidase dose and the patient's still symptomatic, you could add a uricosuric. Probenecid is kind of the gold standard there, but losartan is one I used to prescribe when I was in clinic, when I knew that I had to treat kind of 2 birds with 1 stone. If the patient had chronic gout, but also needed high blood pressure pill, losartan was a good choice. And then rarely used, but if a person has hypertriglyceridemia, chances are they might be on a fenofibrate, and that would be helpful as well for reducing serum uric acid. The last on this list is pegloticase. The brand name is Krystexxa. This is kind of last line, so if the patient's still uncontrolled and symptomatic, then we would consider Krystexxa. It is novel in its action. It's a recombinant form of uric oxidase enzyme, which then gets rapidly converted to an active formulation, which then converts uric acid to allantoin. And the only thing you need to know about allantoin is it's inactive and water soluble. So we convert all this uric acid to allantoin, and then our kidneys excrete it through urine. NSAIDs, again, good choice. Can't really go wrong without it. Just remember kind of all the side effects: gastrointestinal, increased risk of cardiovascular events, so on and so forth. Steroids, prednisone being the gold standard there, highly effective, but timing is an issue. And then also, if a patient's diabetic, you'll want to avoid, or they'll want to monitor their sugars closely. Colchicine is also an anti-inflammatory agent. It's novel in its mechanism. You'll want to initiate this also within 36 hours of an acute attack. And it's usually reserved for patients who are unresponsive to NSAIDs. And it does play a role in the acute setting for Mediterranean fever and also for pericarditis. We don't really know exactly how colchicine works, but it does prevent the activation and migration of neutrophils. As you can see, pain relief is relatively slow. It is metabolized by CYP3A4 enzyme, so just kind of watch out for those strong inhibitors or inducers. You'll notice the half-life is 28 hours, so it's a pretty long time to get to steady state. Bioavailability is only about half, and it's only about half of protein binding. Here's some precautions with colchicine. Just going to go over those. Here's kind of a summary of the drug therapies for hyperuricemia. So, allopurinol wants to be their own thing, febuxostat, probenecid, and pegloticase. Allopurinol can reduce blood levels of uric acid, and it's generally well tolerated. So like I said, it's the current drug of choice. It reduces blood uric acid levels, and it prevents endotophus formation, and causes regression of tophi that have already been formed. So yeah. So it is a xanthine oxidase inhibitor, which is an enzyme required for uric acid formation. If you're dealing with Asians or African American patients, it's worth your while to order in human leukocyte antigen B5801 to see if allopurinol could lead to fatal hypersensitivity syndrome. Like I said, mild side effects can cause cataracts if used for longer than 3 years, and we do want to avoid it with pegloticase. Yeah. Okay, febuxostat is also a xanthine oxidase inhibitor, just like allopurinol. So everything else is going to be the same. Probenecid is a uricosuric. It acts on the renal tubules, which inhibits the reabsorption of uric acid, and then therefore uric acid remains in the blood. And if you need further relief, you can add in indomethacin, which is an NSAID. So probenecid is usually well tolerated, but there are some GI side effects and a risk of kidney damage. Due to some of the interactions, so aspirin and the salicylates can decrease probenecid levels, so just watch out for that. And penicillin, if you take penicillin while you're on probenecid, it can also lead to an increase in the reabsorption. And then methotrexate can increase levels due to probenecid. So this is actually pretty interesting, the penicillin one. You can use this for a therapeutic effect. I had a patient once who had neurosyphilis who was getting penicillin benzathine to treat the neurosyphilis, but he needed to leave, so infusing penicillin into him wasn't an option, and so we settled on giving him penicillin and quote-unquote boosting it with probenecid so that we could get a sufficiently high penicillin level out of them. And then last but not least is pegloticase. It's indicated for IV therapy of chronic gout who in patients have not responded to ULT. And the dose is 8 milligram IV every 2 weeks, and that leads up to a $47,000 bill. There are significant risks of adverse effects, so just kind of watch out for the anaphylaxis. So going back to the question, what is the most appropriate for treatment of this acute gouty attack? And the answer will be naproxen. And you can kind of get clued in here, right? So he had an acute episode 10 days ago, which was relieved by colchicine, which is an acute medication, and an anti-inflammatory. And we can tell that his serum uric acid level is high, abnormal. And so colchicine in this case, at this dosing, would not be correct. In a flare, we wouldn't want to do an intra-articular triamcinolone injection. And then in this answer, combining a pretty high dose of prednisone with naproxen can really lead to some gastric ulcers. And in this question, which treatment is most appropriate? The answer would be D. And we know that allopurinol is more of the slow medication, but we do want to start it at the same time as the anti-inflammatories like NSAIDs, so that we can get it going. Okay, and then last we're going to discuss calcium homeostasis. So a patient's taking alendronate to treat Paget's disease. The patient asks the nurse why calcium supplements are necessary. The nurse will tell the patient that calcium supplements are necessary too. So calcium, sure you know, it's important. 99% of it's stored in our bones. And then the other 1% is in the bloodstream. And of that 1%, about half is actually bound to albumin. And the normal level is 8.5 to 10 mg per deciliter. This right here is ionized calcium. You can kind of think that as free floating calcium. And that's measured a little bit differently, but the normal to that is 1.1 to 1.3 millimoles per liter. When I'd said albumin here before, because calcium is bound to albumin, if the albumin is low for any reason, your calcium will be low, so you want to correct it. So what we'll do is we'll take 4, which is a normal albumin level, and subtract it with the patient's current albumin level. And then we're going to multiply that by 0.8 and add that to the serum calcium to get what we would call a corrected calcium. That's a calcium that you've corrected to account for changes in albumin. Calcium is absorbed in the small intestine, specifically the duodenum. So if you have any patients who've had gastric bypass, specifically bypassing the duodenal route, be prepared for patients who are going to need a lot of vitamin supplementation because of that. Calcium absorption is increased by parathyroid hormone and vitamin D. Steroids can decrease absorption, and calcitonin augments calcium elimination. Okay, so absorption from the small intestine, specifically the duodenum, excreted by the kidneys. It is resorbed in bone, and calcium is regulated by these 3: parathyroid hormone, vitamin D, and calcitonin. So parathyroid hormone, it promotes calcium resorption from bone, and it promotes the tubular reabsorption of calcium that has been filtered by the kidney glomerulus. And PTH helps to promote the activation of vitamin D, and thereby promoting increased absorption of calcium from the intestine, as that is vitamin D's role. So like I said, vitamin D increases calcium resorption from bone and can decrease calcium excretion by the kidney. and it does increase calcium absorption from the intestine. This other product is called calcitonin. It is an actual compound that's released from the thyroid gland when calcium levels in the blood rise too high, and it lowers calcium levels by inhibiting the resorption of calcium from bone and increasing calcium excretion by the kidney, but it doesn't actually influence calcium absorption. Switching gears here, hypercalcemia. Usually it presents asymptomatically, but if it is due to positive, if you're inpatient, usually it's due to cancer, like bone metastasis, metastatic cancer. Or if it's positive and you're an outpatient, likely it's going to be hyperparathyroidism, and these are our sick folks. What causes hypercalcemia? Well, cancer, hyperparathyroidism, too much vitamin D, and then the use of thiazide diuretics. What drugs could we use to treat hypercalcemia? The bisphosphonates are probably the most studied and better choices. They are a little slow to effect, though. It can take 48 to 72 hours. So you can use calcitonin. It comes in a nasal spray, so its onset of action is pretty quick. So it's useful to wait while you're waiting on the bisphosphonate to kick in. And then lastly here, cinacalcet suppresses parathyroid hormone secretion, and it can be used for hypercalcemia secondary associated with hyperparathyroidism. Hypocalcemia can lead to an increase in neuromuscular excitability. It can cause tetany, convulsions, and spasm of the pharynx if taken in high amount. And I do encourage you guys to YouTube for Chostek's sign and Trousseau sign to see the effects of hypocalcemia. And of course, these are some of the causes. And there are some long-term use of certain medications such as magnesium-based laxatives or drugs to use to manage osteoporosis can lead to hypocalcemia. Excuse me. So to treat hypocalcemia, we're looking at intravenous calcium supplementation. That's either going to be calcium gluconate or calcium chloride. And once we've stabilized calcium levels, we'll just go with calcium citrate. We'll do that for maintenance. So the pharmacy does carry gluconate and chloride, a couple of pearls. So you can see that the calcium chloride is way more elemental calcium than does the calcium gluconate. It's about 3 times more potent. With calcium chloride, you got to be very careful because it is 3 times more potent. And so typically we want to give it enough high flow vein, such as the central line, because it is so hypertonic and it can cause the ischemia. Rickets is a disease usually affecting children, which is a vitamin D deficiency. Without vitamin D, you're not going to absorb calcium, so that's why it's important. And there is PTH release in rickets, and the treatment really is to just continue giving vitamin D. Osteomalacia is a term hopefully you're familiar with. But yeah, absence of vitamin D, impaired mineralization of the bone, bowing of the legs. These are all kind of things that the osteomalacia could lead to. And then there's osteoporosis, usually identified with a T-score. It is the most common disorder of calcium metabolism. You can get Paget disease of the bone, which kind of does the opposite. It increases bone resorption. And again, these are some of the areas it can affect, and treatment is going to be bisphosphonates to suppress the bone resorption. And hypoparathyroidism, that can be caused by an inadvertent removal of the parathyroid glands during surgery on the thyroid gland. That I've seen that happen a couple of times. If there is a lack of parathyroid hormone, you can also you get hypocalcemia and all the symptoms that go along with hypocalcemia. And so the treatment, hopefully it would be obvious, is to provide calcium supplements. So having serum calcium into the bloodstream does set off a couple of negative feedback loops. And as you can see here, low serum calcium can increase parathyroid hormone release, which then causes a decrease of thyroid release of calcitonin, and then vice versa. Primary hyperparathyroidism is usually a result of cancer. So with that being said, the agent can increase PTH secretion. Let's see. And the definitive treatment is for surgical resection of both parathyroid glands. But really, to suppress PTH with drugs, you can rely on cinacalcet. Now, this one I bolded because it's more common, secondary hyperparathyroidism, and you see this a lot in chronic kidney disease patients. There is a high level of PTH, and then we treat it with vitamin D to help absorb calcium, and then also the cinacalcet. So cinacalcet increases sensitivity of the calcium sensing receptor on the parathyroid gland, and so doing that helps to lower PTH, calcium, and phosphorus. And those are the dosage schemes. And the nice thing about this is that there's no renal adjustment necessary. This is kind of a cool chart I grabbed from one of my books, but you can see here that this is kind of the normal range of serum calcium, 8.5 to 10. And in secondary hyperparathyroidism, you'll notice that it kind of mirrors the normal line. Usually you'd see, if we were to measure IPTH in these patients, their calcium level would be normal to low. This slide is looking at calcium salts. These are the most common ones you'll see. Calcium carbonate, very common. Tums is what makes, So typically Tums is calcium carbonate, and we usually just stick to that. Because of cost issues, it actually has the most elemental calcium, so you're getting more calcium per buck anyway. So just kind of keep that in mind. These are some of the drug interactions with calcium. So yeah, just like I described in that last chart there, the calcium salts. Let's see here, calcium chloride. Try to avoid chloride at all costs. It can be a dangerous drug. And so typically we'll just make our own. Like I said, highly irritating. If you look at your resources, some of them might still say that there's a drug interaction, and they need help finding it. So if you give calcium when the person's taking digoxin, and you're infusing both, you could precipitate what's called a stone heart. But interestingly enough, that's what we used to think. Is a little nice website of Life in the Fast Lane that kind of breaks it down. Okay, vitamin D helps to promote calcium absorption in the gut. Again, remember, duodenum. And we see a lot of vitamin D folks with deficiencies, and I don't know. It seems to be very prevalent in them. Excuse me. let's see. In the diabetes community, we've seen a lot of vitamin D deficiencies. Now, keep in mind, vitamin D needs to be activated, so vitamin D alone is inert. So it'll undergo two hydroxylations. First hydroxylation is in the liver, so you do need a functioning liver. And then that metabolite is called calcidiol. And then so the calcidiol then gets finally activated in the kidney to calcitriol. And that's the active form. And a normal level would be above 20. So as you can see here, kidney disease, not being able to activate that last step can also lead to a vitamin D deficiency, which then also leads to a calcium deficiency. Some of the toxicities of vitamin D does take quite a bit of discussion, I guess, to see. Let's see where I left off of that. Yeah, strike that. All right. These are some of the forms of vitamin D. We'll kind of go over that a little bit. This is calcitonin. It inhibits the activity of osteoclasts. And if you remember anything about bone formation, you have osteoclasts that help to break down bone. And then the opposite of that are the osteoblasts that build up bone. So with calcitonin, it inhibits osteoclastic activity, which then decreases bone resorption and increases calcium excretion. And it's a nasal spray, so it's actually not too bad, pretty well tolerated, but you can get some rhinitis / running nose and some flushing. Bisphosphonate's an interesting medication. So when you take it, the molecule itself gets incorporated into your bone and it stays there. So this is another drug that inhibits osteoclast activity. It's used for all these indications. Just remember some of the weird side effects. So this one called ONJ, or osteonecrosis of the jaw, typically happens when the dentist is performing some kind of procedure on you. So you do have to make sure that if you're on a bisphosphonate, or tell your patients if they're on bisphosphonates, to let their dentist know so that they can account for that. And then there's also atypical femur fractures, which has been kind of gaining steam in recent years, and seemed to be a good corollary between I lost my train of thought there. Where was it going? Oh, yeah, now I remember. So, atypical femur fractures, it tends to happen with a greater time of taking bisphosphonates. So the longer we have bisphosphonates, the higher the risk of a atypical femur fracture. And so if you kind of look at the mechanism of these drugs, you'll notice that they were taken for years, and so usually past 3 to 5 years is when we start to see more atypical femur fractures as they increase hip and vertebral density. And so if a patient does suffer an atypical femur fracture, the recommendation is to stop the bisphosphonate and see if that person can go without it, and to avoid any more osteoporotic fractures. The bad thing about bisphosphonates is that it does require renal dosing, and so you want to kind of be cognizant of that. And then because bisphosphonates can decrease calcium, you want to make sure you give that patient calcium supplementation if they're using it chronically for osteoporosis. These are some of the bisphosphonates. So alendronate was the first one, very widely used, good for both preventing vertebral and hip fractures. And all the bisphosphonates have poor bioavailability, so just kind of remember that. Yeah, generally safe. Just watch out for the ONJ and the atypical fractures. Riciginate, not very much different. Same thing as alendronate. Abangenate, again, same thing, but this one is much longer acting. So instead of the other bisphosphonates, which you would take once a month pill or once a week, abangenate actually is every 3 months. But again, same thing as the other ones. Just remember that this, in terms of bisphosphonates, is usually second line, and it's only because it's the only one that it doesn't decrease hip fractures. It's only good for the vertebrae. Telidronate, same kind of drug. If you remember to our birth control lecture, we talked about raloxifene as a SERM. And just like the hormone replacement therapy, it has some beneficial effect in osteoporosis or preventing osteoporosis. But again, remember, this is an agent that can activate estrogen receptors, so you got to watch out for kind of the thromboembolic events. Teriparatide is an injection as well. It's a type of parathyroid hormone, and this is the only drug that actually increases bone formation. So this has osteoblastic activity. Black box warning on this is that it is associated with an increased risk of osteosarcoma in animals. So if you have a history of osteosarcoma or bone metastasis, metastatic cancer, or Paget's disease or hyperparathyroidism, you'll want to avoid teriparatide. Denosumab is one of the more newer agents. Came after bisphosphonates. For osteoporosis, it's Prolia. If you're an acute hospitalized patient who's suffering from hyperparathyroidism, they do have a higher dose version called Xgeva. And so it is a rank L inhibitor, and all that does is it prevents osteoclast formation. And for osteoporosis, you're going to do 60 milligrams every 6 months. If you were using it for the hypercalcemia malignancy, the Xgeva formulation gives you 120 milligrams, and you do that every 4 weeks. It does have a long half-life, but it does peak in action in the 10 days. These are some of the adverse effects. So it is, of course, hypocalcemia. But ONJ is also a possibility with this medication. But there is no renal dosing involved with Prolia, so that's a nice thing to know. Cinacalcet is a calcimimetic drug. This is also used for hyperparathyroidism. And what it does is it suppresses PTH secretion. Osteoporosis. So osteoporosis is the most common disorder of calcium metabolism. We use DEXA scans to figure out your T-scores. And of course, the T-score being less than 3 puts you at osteoporosis. So primarily to prevent osteoporosis, we want to do calcium, vitamin D, and see if we can address any lifestyle changes. In women, if we want to treat osteoporosis, we have available to us estrogen. Just kind of remember the contraindications to that. And then the bisphosphonates. Again, the only agent that promotes bone formation would be teriparatide. And then these other agents reduce fractures. And then, again, for men, you can use any of the bisphosphonates along with denosumab. Okay, so back to the question about patients taking alendronate to treat Paget's disease. The patient asked the nurse why calcium supplements are necessary. The answer would be to prevent hyperparathyroidism. And that's it. Hopefully everything was understood, but if you do have any questions, please reach out to me. I'll be happy to answer any questions you may have, and we'll get that quiz up and running for you. Thank you. Take care.